Welcome to video 2 of lecture 7, in which we will discuss case series and case reports, the lowest level quality of research rising just above expert opinion. Again, let's start with a clinical dilemma and one that has come up in very recent times in the medical field. You're a clinical pharmacist in an emergency room, and a patient who was a long-time and frequent user of cannabis products comes in. She describes vomiting in cyclic intervals over the past 2 weeks, and her symptoms are only alleviated by hot showers. Nothing else seems to make a difference. You find this curious as you remember from your physiology and pharmacology courses that hot water actually activates a receptor called the TRPV1 receptor, and the same receptor is activated by the medication capsaicin that's derived from chili peppers. You propose administering topical capsaicin to the patient, as other antiemetic medications, which are medications that prevent nausea and vomiting, are not currently working. 20 minutes following administration of the capsaicin cream to the patient's nausea and vomiting resolve. What can we conclude from your findings, and what type of research have you essentially just conducted? This clinical dilemma is an example of a case report, and a case report is just a description of a unique patient case or unique patient cases. That would be a case series. Cases meaning case series that are used to generate hypotheses. So the difference between a case report and a case series is just the number of cases that you're reporting. One person for a case report and more than one for a case series. Case reports and case series are classified as descriptive studies. So we're just describing what happened to a particular patient at a particular time, and they're usually retrospective. We're almost always describing a unique thing that happened recently. However, they can be prospective in very rare cases, such as when a medication is not yet approved but can be used in an emergent situation. We can do a prospective case report in that case, but for test questions and quizzing purposes, we'll always consider them to be retrospective. The model that we would follow is we take a patient, we describe what happened to them during their hospital encounter, and we generate hypotheses. We never associate the results of the case report with a causal association. Again, thinking through our causality assessment, how we're making these associations and applying them to practice, case reports and case series should never be used to infer causal relationships. Instead, they're used to identify unique phenomena, which may then generate hypotheses, and you might use the findings of the case report to inform further research, which then could determine a causal relationship. So in terms of causality assessment, we have none of the criteria there. So we don't have an association because we're just simply describing outcomes. We're not analyzing anything. We don't have directionality, and we certainly don't have experimentation. From our clinical dilemma, you might say, oh, I saw 3 patients with the syndrome known as cannabinoid hyperemesis syndrome, or CHS. I treated them all with capsaicin, and they all resolved. So you hypothesize that capsaicin might be beneficial for treating CHS. You do not say that all patients should receive capsaicin because there's a causal relationship. You simply say this is a hypothesis and further research must be done. Even though they're the lowest level quality of evidence that we have, case reports and case series do have their role in research. For example, they're very useful for describing new phenomena like adverse drug reactions. They can be used for generating new hypotheses and directing future research. Weaknesses, there are many, so they can't be used to draw comparisons between groups. We lose individual association. Can't be used to determine causal relationships because they don't fulfill the directionality or the experimentation criteria either. And they're vulnerable to something called publication bias, which we'll discuss in a couple of slides. Because case reports and case series are used probably most commonly in the pharmacy field to identify new adverse drug reactions that haven't already been reported, I thought it was a good idea to introduce the class to the Naranjo probability score. This is a score that you can use in practice in which if you find a patient presenting with a unique complication that hasn't been described before, you need somewhat of a more objective way of thinking about whether that adverse drug reaction is truly tied to the medication and not to something else. So the questions that go into the Naranjo probability score include, are there previous reports of this reaction in patients on this medication? Many times there won't be if you're doing a case report. Did the adverse effect occur after the suspected drug administration? Almost always this should be the case. There are very few exceptions to this rule. Did the adverse reaction improve when the drug was discontinued or after a specific antagonist or antidote was administered that would lead you to believe that it's more likely to be due to the drug? Did the adverse reaction reappear when the drug was readministered? Are there alternative causes that could have caused the reaction? If there are, it's less likely due to the drug. Did the reaction reappear when a placebo was given? If yes, then likely it wasn't the drug again. Was the drug detected in the bottle or in the body objectively in toxic level concentrations? If yes, that's a good criteria, although many drugs cannot be detected in the body. Was there a dose response for their adverse drug reaction? Did the patient have a similar reaction to the same or similar drugs previously in their lives? And was the adverse event confirmed by objective evidence? So then you tally all these up, and this can give you a more objective assessment of whether an adverse drug reaction you see in practice was actually due to the medication. You don't have to memorize the scale. If I want you to use the scale, I will give you the full scoring system. When you use your adverse drug reaction probability score, also known as the Naranjo score, you end up with a number anywhere between 0 and 13. And the score can be interpreted in a pretty straightforward manner. If you have an 8 or more, it's very likely that the adverse drug reaction was actually due to the medication and not something else. If you had a 5 through 8, it's probable but not definite. A score of 1 through 4 would mean possible, and if you got a score of 0, it's very unlikely that the reaction the patient is experiencing is actually tied to your medication. Part of the definition of a case report is the lack of a comparator group. We're simply talking about a single patient, which goes back to lecture 2, in which we talked about all the issues with trying to interpret a single-arm study. So all case reports or case series are going to be single-arm studies without comparator groups. Remember, though, that we need comparator groups to control for some of the following things that can impact our interpretation of associations. These include the placebo effect, in which there's an improvement in the clinical condition tied to the expectation of treatment, not necessarily related to the efficacy of the drug. Without a comparator group, we don't know if the patients are improving just because of the placebo effect. There was also regression to the mean, in which you have very outlying values that tend to normalize over time. Again, if you don't have a comparator group, it's hard to tell that this isn't regression to the mean if the patient improves spontaneously. Then there's the natural history, which is just improvement of symptoms related to the natural resolution of the disease, not dependent on the effects of any treatment. The patient was going to be cured anyways. In addition to all of these problems of single-arm studies, case reports have the additional drawback of only having a single patient, and in many case series, it's limited to 2 or 3 patients. So again, in single-arm studies like case reports and case series, there are no comparator groups, so we need to be very cautious about these alternative explanations. Let's talk about biases in case reports and case series. The majority of the flaws dealing with these 2 study designs were listed in the previous slide, and a lot of them had to do with simply not having a comparator group and having a very small number of patients, so that we can't make a statistical association either way. If these single-arm study flaws aren't accounted for, scientists and healthcare providers risk jumping to conclusions and associating a treatment with a particular outcome that might not actually be a true association. One type of bias that is very prevalent in case series and case reports is called publication bias. This is actually a bias by medical journals in which they preferentially publish positive, novel, and groundbreaking results as opposed to negative results. So negative results almost never get published, which is unfortunate because we need those results to have a broader, more complete view of the literature of a particular drug and disease state. For example, if you have capsaicin and you show that it works for this new CHS condition, you will likely publish your results because you had a good outcome. However, if you failed miserably, you likely won't publish for fear of looking like a fool in front of the scientific community. Even if you did try to publish, the journal editor would likely shut you down immediately. However, those negative findings are extremely important in order to balance out the positive findings. If someone publishes a positive case series of 3 patients and you try capsaicin in, say, 20 of your patients and it doesn't work, but you don't publish those 20 patients with negative findings, that totally distorts the medical community's view of capsaicin because they're only reading about the positive 3 cases. Despite some of these issues and biases, there are a couple of areas where case reports and case series are extremely useful. One is disease identification. If you had a previously unknown disease or a variant of unknown condition, you can identify diseases through case reports. If you find a new disease state, and actually this cannabinoid hyperemesis syndrome was just discovered about 2 to 4 years ago through case reports. So these people found that people on cannabis were coming in with this unique vomiting syndrome, and they were only being cured by hot showers. This had been undescribed previously, so they started writing up their findings in a case series, and then they were able to perform a larger study to kind of classify it now as its own disease. They're very good for adverse drug reaction reporting. Identification of rare and serious adverse drug reactions often come from case reports and case series. Actually, these forms of research are the most common source of information that leads to eventual drug removal by the FDA. As a pharmacist, this is a very important area where you can be involved with. If you were trying to talk about new treatment approaches, case reports and case series can be used to generate a hypothesis for further testing. So take capsaicin. It's currently in a lot of case reports and case series. However, we can't make that causal inference, so we need larger studies or better designs to actually tell if it's effective. But it's good to have this generation of a hypothesis from case reports and case series in case it is actually useful. And then finally, as quality assurance. If you see an error in practice which is likely to impact other people, but it could be avoided, you might write a case report about how to avoid that problem in the future. Finally, I want to wrap up the lecture slides with a recap of the strengths and weaknesses of case reports and case series. On the strength side, the ability to identify rare occurrences, identify delayed or rare adverse drug reactions, and to generate new hypotheses about disease states or new treatment options. In terms of weaknesses, no causal inferences can be made whatsoever. There's a large potential for publication bias, and we lack statistical analyses or any sort of causal assessment with these two study designs. Please review the learning objectives at the beginning of the lecture and the material on the following slide to prepare for the quizzes and the exam. What should you be taking away from this lecture? 1, you should be able to identify the strengths and weaknesses of all the study designs that we talked about, know the causal criteria which they fulfill, have a good idea about their study design and the biases inherent in each study, be able to identify the primary uses of cross-sectional studies in case reports and case series. So what types of clinical questions would they be useful in answering, and where is their role in the medical community? Then be able to calculate prevalence for cross-sectional studies, and then if we give you the Naranjo scale, be able to calculate it given the appropriate context. Again, if you are required to calculate Naranjo scores, we will give you all the required information, including the template, so please do not spend time memorizing that.